Welcome to Chapter 3, Overview of Health Concepts for Medical Surgical Nursing. Acid-base balance refers to the level of acidity and alkalinity in our blood that the body needs in order to keep our body functioning properly. This is done by maintaining the body's pH between 7.35 and 7.45, and the body does this predominantly using the lungs or the kidneys or both by controlling the production and elimination of hydrogen ion. If the body's pH falls below 7.35, it is acidosis. If it falls above 7.45, it is alkalosis. So in acidosis, what happens is too many hydrogen ions are present, such as if it's a respiratory issue, respiratory acidosis, or there's not enough bicarb to kind of counteract and could result in metabolic acidosis. In alkalosis, if the pH goes above 7.45, it's exact opposite. There's either too much bicarb, resulting in metabolic alkalosis, or there's not enough hydrogen ions, meaning it's a respiratory issue and the patient is in respiratory alkalosis. Some of the risk factors that could cause somebody to become acidotic or alkalotic include poisoning, a variety of medical conditions to include COPD, uncontrolled diabetes, chronic kidney disease, if they're vomiting persistently, if they've got persistent diarrhea, so they're losing quite a bit of electrolytes as well, if they're in a state of hyperventilation or electrolyte imbalances, especially potassium tends to be one of the biggest culprits. Compensation is the body's attempt to restore that pH back to the normal range of 7.35 to 7.45. This graphic, the dotted pink lines refer to respiratory compensation and the dotted blue lines refer to metabolic compensation. So let's say that we have a patient that is acidotic and it's a respiratory issue. So they're in a state of respiratory acidosis. Then what's going to happen is the body's compensation mechanism is going to be that there's going to be an increase in the reabsorption of bicarb in an attempt again to pull that pH over to the right. If the reason for the acidosis is a metabolic issue, then the compensation on the respiratory side is going to be that the respiratory rate is going to increase in an attempt to drop off and decrease and blow off PCO2 to try to pull that pH back to the right into the normal range. Now let's look at states of alkalosis. So if the patient is respiratory alkalotic, such as they were hyperventilating, what will end up happening is the pH will be increased above 7.45. And the compensatory mechanism on the metabolic side is going to be that we're going to try to drop off and decrease bicarbonate, decreasing the bicarbonate to try to pull the pH back down to less than 7.45, hopefully not less than 7.35. If the patient is metabolic alkalotic, such as with renal disease, the compensatory mechanism on the respiratory side is going to be to hypoventilate. That way, PCO2 will increase, making the pH go to the left, meaning a little bit more acidotic. And again, this is compensation if the patient is in metabolic alkalosis. When we care for patients with acid-base imbalances, we want to look at their entire health history, all present and recent signs and symptoms. We want to know all their medications, over-the-counter drugs, and supplements, as those could cause imbalances as well. And we may be having to do some arterial blood gas monitoring or ABG monitoring. If there's a suspicion that the patients are going to need serial ABGs or more than 1 or 2 ABGs, that means generally that the patients are very sick and the providers may opt to insert an arterial line With arterial blood gas monitoring, if the patients don't have arterial lines, it generally means that we're going to do an arterial stick. And 99% of the time, that's done in the radial artery. That carries some risk and it's extremely uncomfortable. So, if those patients are going to need multiple ABGs, again, we'll start an arterial line. If not, let's say that we want to check somebody's pH and they're not a candidate for an arterial line, and maybe we think it's going to just be a snapshot one and done. There is an option for us to do a venous blood gas. The pH parameters and, of course, the PCO2 and O2 values are going to be different because we're sampling from the venous side versus the arterial side. These health promotion strategies pretty much apply to every patient population. We're going to dive deep into the interventions and the treatments in Chapter 13, which is the fluid and electrolyte chapter. And ultimately, we're going to treat the underlying cause. For example, if somebody is acidotic for a respiratory reason, they're huffing and puffing, then we're probably going to address the respiratory issues to try to make sure that we maximize gas exchange and help the patients get rid of their CO2 and bring that pH back down to the normal range. Towards the very end of the semester, we will cover in depth the cellular regulation concepts, genetic and physiological processes that control cell growth and replication. So, in some instances, those processes are benign, in some instances, they're not. And so, again, in our cancer chapter, we'll talk about that. There are a variety of reasons for why cell regulation might be impacted. Just the mere process of aging, where those of us that are blessed will just increase the risk of developing abnormalities such as increased masses that may be benign, they may be malignant. Smoking tends to be one of the biggest culprits for the development, risk factor for the development of multiple cancers. General poor nutrition and general health. Physical inactivity is a huge one too. Exposure to pollutants, radiation, even certain medications such as chemotherapies themselves. So in this instance, it's the chemotherapies targeting the malignant cells that could still manage to impact healthy cells and impede on the cell regulation of those cells as well. And then any genetic predisposition, a big one, for example, might be the development of breast cancer and people that carry the BRCA cell mutation. As I mentioned, the consequences of impaired cell regulation is going to be cell growth that could be benign or malignant, which is also cancerous. We're going to assess history, physical exam, and a multitude of diagnostic testing. Health promotion strategies for impaired cell regulation is going to include things targeted to minimizing the development of impaired cell regulation as a whole. That's primary prevention. Secondary prevention is going to be screening, trying to catch things early, trying to prevent the cell regulation into developing into something potentially malignant. And then finally, tertiary interventions are those things that are done after impaired cell regulation has occurred. Now the patient has tumors, whether they're benign or malignant. Those interventions could include removal. They could be biopsies. They could be lumpectomies, I should say, surgery, radiation therapy, chemotherapy. It's targeted therapy that could include hormonal, and there's so many new things that that are out there. Biological therapy. They could potentially target the point at where the stem cells grow. So there's quite a few different things that could be done today, but these are targeting now that the impaired cell regulation has occurred and the tumors are already present. In week 5, we're going to discuss the hematologic system, including clotting. We will learn about the clotting cascades and risk factors for excessive or increased clotting, as well as on the other side, risk for bleeding and decreased clotting. Physiological consequences of issues with clotting, either on the high side or the low side, could be very detrimental. If in instances of increased clotting, We're going to clot where we don't want to. And one of the biggest risk factors is going to be, for example, with immobile patients, all patients in general, because they're not generally, if they're in the hospital, they're not moving as much. Some patients are higher risk than others, of course. So if the patients develop clots in the deep veins of the legs, that could end up in a deep vein thrombosis that potentially could break off and travel and lodge somewhere else, causing either a pulmonary embolus or worse. It could lodge in the vessels within the brain and cause a CVA or a stroke. In instances of decreased clotting, there could be undesirable prolonged or any kind of bleeding pretty much. So for those patients, if they have a decreased clotting, we're going to look for things that would indicate that they're at risk for bleeding, such as bruising, petechiae. We're going to look for potentially scan for occult blood in the urine. We might send off samples for the stool. We'll look at gums, all the mucosa that's at high risk. It's very vascular, so they're at risk for bleeding. If they have an issue with increased risk for clotting, again, we're going to look for risk for thrombosis. In the legs, we'll look for the presence of pain, redness, warmth. If there's a risk for arterial thrombosis, we may not be able to see it externally, but as far as like the redness and things like that, but we'll see signs potentially of decreased perfusion to the distal point from that. So they actually might be discolored. The pulses might be impacted. With arterial thrombosis, that's definitely a higher. They're both bad if whether they clot on the venous or the arterial side. But in the case of arterial, of course, the potential is great for tissue ischemia and tissue death. So that's considered a critical rescue. As far as teaching patients that have decreased clotting ability, we need to make sure that we tell them that they have to report any signs that they notice of unusual bleeding or bruising immediately. For patients on the other side of the spectrum who are at risk for clotting when they're not supposed to, we need to make sure that they remain hydrated, right? The last thing we want them to do is to have hemoconcentration that'll be predisposed by being dehydrated. We want them to avoid crossing the legs. We want we don't want anything to impede blood flow. We want things to keep moving. So you want to encourage them to ambulate frequently. Smoking, again, there it is. If they can, smoking cessation is so important. And we want to teach them to report any signs of pain, swelling, any warmth, anything that would indicate that there's a potential DVT or any kind of embolus. Patients that are at risk for clotting are also going to be given potentially a variety of different medications that could include direct thrombin inhibitors, anticoagulants, and antiplatelet medications. And we're going to cover these in week 5 when we talk about chapter 33. In week 11, we're going to talk about caring for patients with conditions of the central nervous system and also critical care of patients with neuroemergencies. At that time, we will discuss more about cognition. We will contrast between dementia, delirium, and depression. We're going to really focus on making sure that we can identify that they're not the same, and we'll talk about what some of those characteristics and the differences are. In week 11, we will again discern between different types of cognition disorders, global versus focal, and then general focal cognitive problems altogether. Here's a list of risk factors for impaired cognition. There's that advanced age again. Polypharmacy, way towards the bottom, that can also be another risk factor as well. Keep that in mind when we're caring for our patients. You're going to see that more than you'd think. Impaired cognition can manifest as loss of memory, short-term and/or loss of long-term memory, disorientation, delusions, hallucination, just acting and inappropriately, unable to control emotions, impaired language, impaired reasoning, and decision making. For the assessment piece for these patients, we'll still always get a history. We'll discuss later on in week 11 the different assessment tools that we can use, the CAM and the mini-cog, some of the diagnostic testing, and then other neurophysiological testing that we can participate in. Health promotion strategies for patients that have impaired cognition. Ideally, we'd like for them to avoid risk factors. That's not always possible. Kind of always usually identify those risk factors after the fact. We want to also keep the working, functioning parts of the brain. We want to stimulate the intellectual parts as much as possible. There's a lot of research that talks about how certain mental exercises might help preserve certain functions. It's really interesting. There's maybe something to that. And then our interventions are going to focus on safety, keeping the patients oriented. In cases of dementia, we might try certain medications. Also, in cases of delirium, we want to try to identify what the potential cause might be and reverse and address those. Now, comfort and pain are not their own chapters for this particular course. That content is actually going to be spread and embedded across multiple chapters. So comfort means the state of well-being, pleasure, basically not being in pain and hopefully not being stressed. Unfortunately, the response kicks in with illness and of course when there's pain. There can be physical or psychological and emotional reasons why a patient's comfort might be impacted. So the physiological and psychological consequences and how this might manifest is the fight or flight is activated, so the patients will display those signs. They might complain of persistent pain, they might be anxious, they might have general discomfort, and then also manifest emotional stress. Bottom line is, if we think that the patient is in pain, we got to ask. We want to ask them if they can rate the pain on a scale, usually for adults, on a scale of 0 to 10. We might have to get creative and use a variety of different tools for children and patients that can't communicate. Sometimes there's a language barrier. In addition, there's other things that we can do if they can't speak. Craft your questions in yes, no, so that they can nod or shake their head, or sometimes we have to ask patients to write notes. Maybe we can use an interpreter if need be. We want to identify and treat the underlying cause. Health promotion strategies are going to include, you can predict if the patients are getting ready to undergo something that's going to be painful or potentially emotional and distressful, we can intervene ahead of time and plan our interventions. An example of this might be is somebody just had a complete hip replaced and PT is going to come in about 3 hours to start getting them out of the bed for the first time. We can certainly plan pain intervention therapies. We can give them some medication before so that we can plan that they'll get their physical therapy when the medication is at its peak effectiveness. And then after the physical therapy, if it's appropriate, we can perhaps additionally give them some ice. So in this instance, is a good example of we would collaborate with interprofessionals as needed. Elimination is excretion of waste from the body, and that can happen by either the GI or the urinary tract. We're going to cover the urinary portion way back in chapter 58 through 59 in week 10, and then the bowel elimination we will cover in week 7. We'll talk about the risk factors that impede elimination in both GI tract and urinary tracts, to include aging, neurological disorders. We'll talk a little bit more about neurological disorders in complex 2 as well. Spinal cord injuries, I think there'll just be a quick mention on that. Again, that's more complex 2 content. Excessive laxative use we'll cover during the GI portion. Infections, conditions such as irritable bowel disease and syndrome, and also other disorders in the urinary tract. Problems with elimination can manifest as tissue integrity damage, fluid and electrolyte imbalances, and anxiety, depression. Bladder rupture, in my 30 some odd years of nursing, I've never heard of a bladder rupturing. I'm sure it's possible. Bowel impaction, intestinal obstruction, very common, unfortunately, and can become life-threatening. Especially if there's leakage of the GI tract contents into the abdomen that can cause an infection and an emergency and potentially sepsis and septic shock. For our assessment, we're going to look at these patients and see their risk factors, treat underlying causes before they become big issues. We'll assess the peri area, the buttocks. We're going to be monitoring these guys frequently, good vital signs, looking for trends. That's so important. We'll talk again more in detail about this when we get to those chapters. A lot of labs that we can check depending on which system we're looking at. Health promotion strategies we'll talk about for everybody. Adequate nutrition and hydration, specifically for the GI tract, high fiber diet. 99% of the time that's going to work. There's a small population where we would not want to do that. If we can, we want them to toilet and void promptly. Bulk forming agents, again, maybe 99% of the time that's appropriate. General exercise. The gut loves exercise to function properly. Our interventions are going to include watching and tracking for any fluid and electrolyte imbalances. We might have to do some teaching. We might have to give them stool softeners or bulk forming agents. And in cases where the others are not working, we might have to give them mild laxatives. If they're having urinary retention and we can't resolve that, they might have to have either an in and out catheter or an indwelling Foley. We will discuss fluid and electrolyte imbalances right after this chapter. That's regulation of body volume, which of course where fluid goes, so do electrolytes. We'll talk about osmolality. We'll talk about dehydration versus fluid overload. Again, we'll cover some of that content with some of the other disorders where we start talking about renal disorders or even cardiac, such as specifically heart failure where we retain fluid. And again, we'll talk about electrolyte imbalances throughout quite a few of the remaining chapters. Here's a list of some risk factors for fluid and electrolyte imbalances. Fluid and electrolyte imbalances could manifest as signs of fluid deficits or overload. So let's say that if we think that they're wet, we might auscultate very wet, junky lung sounds, or we might see peripheral edema. On the other side, if they're a fluid volume deficit, meaning they're intravascularly dry, we might see the compensatory mechanism for a low blood pressure being the increase in heart rate or tachycardia. On the electrolyte deficit side, we're going to talk more in detail and really hone in on a handful of electrolytes like potassium, magnesium, the more frequent, and some of the complications that can occur when those imbalances happen. Our assessment is always going to start with a complete health history. We're going to look for the risk factors and look for the active reasons why we might see these electrolyte and fluid imbalances and target those. We're going to assess one of the biggest, easiest ways to try to figure out whether somebody is fluid volume deficit or overload is weighing. And it has to be done with precision. It can't just be willy-nilly. Whatever mechanism that we're using in-house to weigh the patient, it has to be the same every single time. There's a variety of lab tests that we can also do that can help us determine whether the patients are potentially fluid overloaded. When we talk about our cardiac block, we'll talk about something called BNP. And then the lab tests, of course, the electrolytes will show whether they're within range or if they're high or low. Continuing on health promotion strategies for patients that are at risk, we want them to drink adequate fluid. Now, here we're listing 8+ glasses of water. That might be contraindicated in some patients that have renal disease or they have heart disease. The heart disease, I mean specifically heart failure. We want them to have a well-balanced diet. Our interventions may target if they're fluid volume deficit, we're going to replace those fluid. If they're overloaded, we might have to restrict and then maybe give them some diuretics per order. Sometimes the treatment is not necessarily a diuretic, but the treatment might be something to help the heart pump more effectively. That particular content will be addressed in complex 2, but there's different ways to address fluid overload. Electrolytes, we're going to manage those based on whether they're high or low and specifically what we're dealing with, which electrolyte. The concept of gas exchange is not its own chapter. It's going to be discussed across multiple chapters to include the pulmonary ones that we'll cover in week 3 and also some cardiac disorders. I think this is a concept that some students tend to struggle with, and it is a nursing diagnosis, so we really are going to address this multiple times. You'll get a chance to really employ this also and look for impaired gas exchange. You're going to see it for sure in your patients in the clinical environment. So normal gas exchange involves the process of exchanging oxygen for carbon dioxide. That happens at the alveolar capillary membrane. And so what we're looking for potentially is signs that the patient's at risk or that there's impaired gas exchange. Some risk factors are going to be either on the acute side or chronic. Acute meaning, okay, somebody's got a pneumonia that suddenly developed, and so they've got extra gunk, for lack of a better word, that is impeding that alveolar capillary membrane from allowing the gas to go back and forward. There also could be some cardiac contractility issues that impede the blood flow so that the alveoli would normally have a good blood supply. That's somehow impeded, and so you don't have what we call enough ample boxcars going around the alveoli that are ready to receive oxygen and transport them to the tissues. There could be a variety of those issues. It'll make a lot more sense when we start talking about those disease or disorders themselves. Some of the other risk factors include predisposing lung conditions. There is smoking again, being prolonged in a state of prolonged immobility, and environmental exposure to pollutants. Impaired gas exchange means that there's inadequate transportation of oxygen to the tissues, the body cells, and the organs. It's retention of carbon dioxide. Normally, we would throw that back in the alveoli and we blow it off. So when we have that happen, we already discussed, we know it's going to happen to pH. Potentially, it's going to pull to the left, meaning those patients are at risk or will become acidotic. But then more importantly is that the impeded oxygen delivery to the tissue cells could result in cell death and tissue death. The diagram there shows some at-risk populations, post-ops, because they're going to be recovering from the effects of anesthesia. We'll talk about that very quickly when we talk about perioperative nursing. Immobile clients, they are at risk for developing something called atelectasis. You will hear that term quite a bit in the clinical environment, so we'll discuss that in depth when we get to that content coming up very quickly in week 3. Patients that are anemic or bleeding, what happens is they're losing hemoglobin, and that's how we carry oxygen. So those patients are at risk for altered oxygenation. Geriatrics as a whole, there are a lot of different changes that happen. Just becoming older predisposes that patient population for so many different things. Our assessment for patients with impaired gas exchange, again, we're going to start with a complete health history. We're going to really focus and zero in a good respiratory assessment. We're going to look at things such as what their entitled vital signs are going to be very important, but we'll look specifically at breathing effort, oxygen saturation, or SpO2. We'll assess cap refill, how their expansion of the thorax is working. Are they using any accessory sounds, accessory muscles? What do their lungs sound like? We'll look for all these different things, including a variety of lab tests, diagnostic testing. One of the things that we could do that we mentioned earlier are arterial blood gases, or we could do a venous blood gas if we don't want to poke them in the radial artery if they don't have an arterial line. We could do so many different things and so many different tests depending on what we think the primary reason for their gas exchange issue is. The health promotion strategies for people that have impaired gas exchange are going to be infection control. We're always concerned about the development of potentially nosocomial pneumonia. Smoking cessation is always good if the patient's willing. Make sure they're up to date on their immunizations. We want to make sure that they're aware of potential exposure. Influenza used to be a seasonal thing. Now it's a year-long thing. And of course, we have COVID to worry about. TB, we have trends every now and then. Overall, the United States doesn't tend to be a very high area of concern for TB, but again, we tend to have trends that pop up every now and then. Interventions could be all over the gamut. They're going to target the underlying cause. There are so many things that we could do. We're very powerful to help these patients. Things like offering incentive spirometry that sometimes we forget about. I'm a big fan of that. Coughing, deep breathing, positioning them as semi-Fowler unless contraindicated, which be mindful that, and we're going to talk about this a little bit later on too, There are some patients where we would not want to sit the patient semi-fowler. An example would be somebody that just had a hip replacement. It depends on whether they did an anterior or posterior approach, and we'll talk about that. We'll monitor pulse oximetry as part of the regular vital signs. We might have to make sure that they're getting their oxygen therapy as ordered. Glucose regulation is not its own chapter. We'll talk about this a little bit more when we discuss diabetes later on. You will employ this concept quite a bit in your clinical environment. Sometimes there are medications and disorders that, other than the pancreas and diabetes, that could impose or impact glucose regulation. We'll talk about that as we go through the rest of the semester. We will talk about the immune inflammatory response in detail in Complex 2, right before we start talking about sepsis and septic shock. As far as the concepts of general inflammation and immunity, for this particular class, we will discuss in week 12. We will learn about the different types of immunity, natural, artificial, passive and active, as well as antibody mediated and cell mediated. The risk factors for impaired immunity are listed right here, beginning, of course, with advanced age. Lower socioeconomic groups can be more at risk. Non-immunized adults, you will learn about that as well when we talk about that block later on in week 12. Chronic drug use, substance abuse, not practicing healthy lifestyles, and then there could be a genetic predisposition as well. The manifestations could be such a variety of different things. We'll learn about the different immunoglobulins and autoimmune reactions, some disorders. We'll talk about all of that a lot later on in chapter 16 on week 12. Here's how we're going to approach our assessment. Health promotion strategies. Target avoiding infection. That's true for any patient. We're always going to employ frequent hand washing. Social distancing is as needed, immunizations, and promoting a healthy lifestyle. If we have potential issues or concerns with decreased immunity, there's also some additional things that we can do. Barriers, we can use reverse isolation. We can use a variety of different accoutrements to include, they start with good hand washing, gloves. We might have to use masks, gowns, all of the above. Infection is week 12 content. That's the invasion of pathogens that then multiply and cause disease or illness. Could be any of these: bacteria, viruses, fungi, parasites, or protozoa. Here are the risk factors, and again, we'll discuss these in great detail in week 12. Some of the consequences of infection: if it's a localized infection, it could manifest as a cellulitis. If it's systemic, what we'll see is blood work will reveal an increased white blood cell count as the body's trying to fight off the infection. That's not always true, such as if it's a fungus, we might not see an increase in white blood cells. There's also patients that they can't manifest an increased white blood cell. We'll talk a little bit more when we get to that chapter. Patients that develop a systemic infection where whatever the whatever the microbe is that invades the body ends up in the bloodstream, they could develop sepsis and then septic shock. Our assessment components are listed here for you. Health promotion strategies for infection prevention could be primary or secondary. Primary would be limiting exposure or potentially immunizations. And secondary prevention means things that we do to detect early disease, the early presence of infection. Interventions could be a variety of different things to include fluid and electrolytes. We might give antibiotics / antimicrobial drug therapy, offering rest and good nutrition, and general supportive therapies. The concept of inflammation, again, is week 12 content. Inflammation is not always a bad thing. It's a normal cell response to injury, allergy, or invasion by pathogens. Inflammation could be either acute or chronic. Risk factors, well, we're all at risk. And then there are some populations that are at risk and more susceptible to chronic inflammation. There are some consequences of chronic inflammation as well. Presentation of inflammation might include seeing redness, uh, feeling warmth, seeing swelling. Patients complain of pain or discomfort, and that could result in also hopefully just a temporary loss of function on the affected part. Our assessment, again, history, we're looking for any local or systemic symptoms, and then there's a variety of lab tests that we can do. We'll talk about health promotion and interventions again in week 12. The concept of mobility, again, is not its own chapter. It is implied and stressed across multiple other chapters to include in chapter 12, we're going to be talking about impairment and assessment of the musculoskeletal system that could result in a variety of different consequences to immobility. Those are listed on the right-hand side. They could result in pressure injuries, all sorts of different complications. Constipation, remember I told you the gut loves to move around? Well, this is what happens when we have immobility. They could have disuse osteoporosis. We'll talk about osteopenia, osteoporosis a lot later on. They could develop basically misuse or non-use muscle atrophy. Atelectasis, we'll talk about that in our lung chapters. DVT, we already mentioned. They could also develop urinary stasis and also urinary calculi. Here are our assessment pieces for patients at risk for immobility. We will talk about how we assess muscle strength. We're going to try to avoid terminology such as weak, strong. We use a 1 to 5 musculoskeletal strength scale. That's what you should be using in your charting and in your clinical paperwork. We're going to be looking for range of motion, identifying patients that are at risk. That's part of our health promotion strategies. We want to teach the patient's range of motion and also the heel pump. That's to keep things moving and make sure that there's no venous stasis that would risk them for deep vein thrombosis. Make sure that they can perform their ADLs and we support them as needed. We want to ambulate patients. I've actually seen this across my nursing career that when I started in the early 90s. We always knew that ambulation was important, but I'm not sure that we always prioritized getting patients out of bed. I know that in the early 90s when I was taking care of patients that had just had a coronary arterial bypass or a CABG, we wouldn't necessarily push them out of bed very quickly. And now today, it's incredible. We'll see people ambulating that have all sorts of lines coming out of their chest. They'll have chest tubes. They'll have pacing wires. Well, I don't think they really like to move them when they have pacing wires, but it's incredible. We just did a rotation over at the Heart Center near University campus at the Methodist out there. It's unbelievable what they can do. They have a variety of different patients. They'll have embedded pumps, and these guys are walking up and down the hallways. It's really fascinating how far our practice has come. These are all our interventions. Passive range of motion. There are also devices that can assist our patients in moving their lower extremities if need be. We've got to turn these patients and reposition them pretty frequently. I could go on a soapbox about how frequently that should be. Keeping their skin clean and dry, making sure that we promote adequate nutrition, hydration, all these different things for patients that have impaired mobility. In week 7, we're going to talk about patients at risk for malnutrition. Nutrition is the process of ingesting and using food and fluids. It involves multiple things: proteins, carbs, fats, vitamins, minerals. Patients that are at risk, there's the older population. Even patients that are considered obese and morbidly obese, they are still malnourished. They still can be malnourished. In week 7, we'll talk about the physiological consequences more in detail for malnutrition. Here are our assessment pieces. We'll discuss those again in week 7. It is important to note that you will need to know what the normal BMI is, the body mass index. We will collaborate with nutritional medicine as needed for patients that are malnourished. We run into these patients quite a bit on both sides of the spectrum, more so, I think, in the malnourished. This was again something that I've seen in my practice that has increased tremendously. Back when I started my nursing practice, I remember that we would keep patients NPO for day after day after day, and then somewhere along the line, around the maybe 2003 timeframe, we realized how important nutrition was for healing. I know that for our young casualties, they had burns and blast injuries that as soon as we knew their gut was working and it was safe to do so, we started giving them tube feedings quite a bit early. It was actually pretty fascinating to see. So it's really important. Nutrition is very important as early as possible. So we'll consult with nutritional medicine, whether a patient is on the high end or the low end. There could be some drug therapies that we might have to give them. And for patients that are morbidly obese, bariatric surgery might be something that is in the picture. Bariatrics have come a long way. I think that some insurances have realized that the cost of paying for bariatric surgery might outweigh the costs of paying some of the consequences if the patients don't lose weight. Pain is an unpleasant sensory and emotional experience. It's subjective, so we want to make sure that we take the patient's word for it. There's a few different types and categories. Acute and persistent, meaning chronic. It could be nociceptive, it could be neuropathic. We'll talk about some different, like visceral pains and et cetera, as we go along in the chapters. Who's at risk for pain? Anyone. It's not just those that suffer acute trauma. Sometimes even the therapies that we employ could be very painful. We expose our patients to painful procedures such as starting big lines, central lines. We're inserting that introducer that starts with a scalpel pierce, especially if somebody's having a chest tube insertion. I have heard that the chest tube withdrawal and removal is actually more painful than insertion. I don't know. I've never had a chest tube, knock on wood, hope I never do. But know that anybody is at risk for pain. The consequences of the presence of pain could be all over the gamut. Years ago, I was the clinical nurse specialist for a trauma unit here in San Antonio. And a night nurse was treating a trauma patient for hypertension all night long. I had a conversation with him in the morning, something to the effect of, "Would you think that maybe he's in pain?" He was dumbfounded. This guy was intubated, and so the nurse was dumbfounded. So I talked the day shift nurse after shift exchange to give him an opioid. At that time, the flavors of the month were we loved giving fentanyl. But lo and behold, as soon as we treated the patient for pain and gave him a little bit of fentanyl, it's amazing how compliant he became. He became more relaxed. And I don't remember the numbers, but I remember that his blood pressure came down within the normal range. So please make sure that we prioritize assessment and treatment of pain. The assessment of pain is something also that I see students struggle with in this rotation, and I'm not exactly sure why. So these assessment pieces are not listed in order, but I think during your fundamentals or your health assessment class, you learned the PQRST acronym. When we're charting that the patient is in pain, we want to not necessarily just list, whether it's a 4 out of 5. We need to look at things such as where it starts, what's its quality, what are its characteristics, does it gravitate or does it travel anywhere else? So the acronym PQRST, P, provoking factors. What made it come on? What were the precipitating factors? What were you doing? So did your pain start when you tried to sit up, for example? Q is quality. So ask them to describe it. Is it stabbing? Is it dull? Is it burning? R, region and radiation. Where is it? Does it radiate anywhere? Is there pain anywhere else? S is severity. So on the pain scale, if need be, on a 0 to 10. And then T, time. How long have you had it? Does anything make it worse or make it better? Interventions for pain can be pharmacologic or non-pharmacologic. We usually employ active therapies in the acute care setting. I'm not sure exactly what class it is, but it might be behavioral health. They really have emphasized the point of using things like distraction therapy. That's all well and good, but if the patient actually has an acute reason to have pain, we really want to try things like repositioning or maybe ice, heat, something actively to try to address the actual pain. And you can use distraction if all other things are failing. Pharmacologic opioids. We can also give anti-inflammatories, not necessarily controlled substances, and we might have to do combo therapy. Perfusion refers to adequate arterial blood flow, so adequate carrying of oxygenated blood to the peripheral tissues. Then blood that's pumped by the heart to the major organs is deemed central perfusion. So that is dependent on a couple of different factors. You have to have a good pump, meaning the heart's pumping adequately to keep things moving. Hopefully there's not a gas exchange issue so that when the hemoglobins come across that alveolar capillary membranes, they're ready to receive the oxygen and they can carry the 4 oxygen molecules on the hemoglobin and off they go. Adequate blood supply is very important. We got to make sure that we've got adequate hemoglobin. Risk factors for impaired perfusion. The two categories are non-modifiable, can't do anything about it. Modifiable, can do something about it. So for the modifiables, there's smoking at the top of the list. Don't smoke. It really has some different chemical and cell level impact. Lack of physical activity is so huge. Just being mobile gets things perfusing much faster. Being obese, think about it this way, guys. So if you have a sprinkler system, like one of those old-fashioned sprinkler systems that you hook up to the hose, and you're trying to irrigate a small front yard, a small lawn, it's going to probably do an okay job. Now you're trying to irrigate a football field with that same sprinkler system. Now the effects and the ability to water that in that huge lawn or that huge field is not going to be as effective. Same thing happens when we increase basically our BMI. Heart doesn't necessarily become more efficient per se, so that does impact perfusion. Impaired perfusion will manifest peripherally in the lower extremities. They might appear cool, pale. They might be cyanotic. They might develop skin ulcers. They might develop gangrene. This diagram actually shows the difference between lesions, whether the issue is impaired arterial flow or impaired venous flow. So arterial insufficiency on the left, you'll notice that the wound is not as jagged. It's kind of round. It's got rounded edges, relatively flat. The venous side is more jagged. Both again here are there. We'll talk about this a little bit later on when we talk about vascular disorders, their location, whether they're medial and lateral. Then central consequences of impaired perfusion could include myocardial infarction. Okay, so blood flow is impeded to the blood vessels that feed the heart muscle. Blood flow impeded to the vessels that feed the brain could result in a stroke. And blood flow impeded to the system would cause shock. And assessment again includes history, looking at family history, and then signs and symptoms of any impaired or peripheral impairment, central or peripheral impairment, excuse me. Health promotion. Get them to stop smoking, get them to exercise. We want to do regular screening, make sure they've got adequate nutrition. Our interventions may be vasodilating drugs. So if they've got impaired blood flow, something to open up the vessels. If something is impeding blood flow that vasodilation is not appropriate for, then they may need to have surgery. An example of this might be is a patient that has atherosclerosis. This is basically a buildup of plaque on the inside of the lumen of the arteries. That's going to make the lumen smaller, which is going to decrease blood flow and make it a little bit of a more high pressure system. That happens a lot, especially in the carotid arteries. So those patients, if blood flow is being impeded to the brain, they're at risk for developing a stroke. So if they catch it early, they could take them to the operating room and address that atherosclerosis, that plaque in the carotid arteries. That's called a carotid endarterectomy, abbreviated CEA. They can put a stent in there to promote blood flow, so hopefully that will help the patient prevent having a massive stroke. Moving on to sensory perception, which is our ability to perceive and interpret sensory input from our senses, and hopefully we're making some meaningful responses. The risk factors are listed there for you. We'll apply those throughout the semester. One of the biggest, again, is aging. There are chronic diseases that also impede sensory perception. One of the biggest diseases is diabetes. Cranial nerve damage, also drug therapy can cause sensory perception issues, physical trauma, and also occupational exposures. Intact senses are critical for many processes, for the ability to communicate, to maintain balance, to be able to perform ADLs, to enjoy, existence. And some of the consequences when patients have impaired sensory perception are there listed for you. So we have to be aware of those, and we have to adjust how we deliver nursing care in some instances, how we communicate with patients. As we adjust the plan of care, we also want to maintain the patient's dignity and independence. Our assessment begins with history, looking at risk factors, asking if the patient uses any kind of aids, glasses, contacts, hearing aids. We don't normally assess vision and hearing in the inpatient environment. Maybe we should do a basic assessment more often than we do. Keep in mind that if the patient is struggling with certain tasks, that we may have to ask whether in fact they need their glasses, or they're not even aware that they may have visual impairment. General health promotion strategies and education for patients include primary, meaning avoiding risks, using eye protection, using ear protection. Secondary means also making sure that they participate in screening, at least getting an annual or semi-annual eye exam if they're having active issues. Our interventions are going to target the impaired sensation. So, if it's a hearing problem, we want to ask the patient what works better for you. Sometimes it's not a volume issue where raising your voice is going to compensate for their hearing loss. Sometimes it can be the tone in our voice. So, let's communicate and ask the patient. Also, if somebody has a visual impairment, again, communicating with the patient and asking what works well for them. I had a family member, he's since passed, but he was blind for most of his adult life. And it was actually fascinating. And I was so impressed and proud to see how he navigated the world. When it came time to eat, for example, his wife knew exactly how to place the tray and where to place utensils. And he was very independent. Even to see him functioning on the day to day with handing out currency. Today it's pretty much nobody carries cash anymore. But back in the day, he did, and he had ways to figure out which was a $5 bill, which is a $20 bill. So we won't be dealing with money with the patients, but the intent basically is make sure that we communicate with the patients to find out what works well and what we can do to make sure that we communicate with the patient effectively. We need to be aware and mindful of the patient's sexuality, knowing that sexuality is not the same as gender identity. As we establish rapport and communicate openly with our patients, we can become aware of their thoughts and self image. We need to be open to learning and know that patient needs in these dimensions are just as important as traditional medical surgical categories, if you will. And discussing a patient's sexuality with them can be a bit daunting. So make sure that you practice what you learned during your health assessment class in preparing the environment appropriately before you start having these conversations with the patient. And health promotion strategies will start by a physical examination. It could also include an STI screening. As we identify patient needs, we may need to reach out to a qualified provider that can address those concerns and issues. We may also administer some pharmacological therapy as ordered by providers as well. Throughout the semester, we will assess and address issues of tissue integrity, which is the intactness of the integument and mucous membrane structures. Those at risk include the elderly, patients that have certain medical conditions. Diabetes, again, is one of the biggest culprits. Malnutrition, and could be musculoskeletal issues, immobility, also some neurological disorders. Dermatologists will tell you unprotected skin from the sun damage. Our skin is our largest organ system and it predominantly serves to protect us. So when there's impairment of that structure, we could potentially open up the window for entry of pathogens causing a localized cellulitis that can develop into sepsis, which would be a systemic infection. While the causes might be different, the consequences could be the same, including pain and also impairment with healing. Our assessment begins by considering their history and chronic health problems, what meds are they taking. There are some medications that impede wound healing, also impede peripheral perfusion, which also ties back into wound healing and general skin health. The best time to do a full skin assessment is during bathing. And there are risk assessment tools. The one most commonly used is the Braden scale. It's a point value that's assigned that gives you an indication of how at risk they are for skin impairment. Some lab values that we will assess that tie back into the patient's nutritional status are serum albumin and prealbumin levels. Keep in mind that albumin by itself, not the prealbumin, but albumin tends to take quite a bit to adjust to go up and down relevant to nutritional status. So prealbumin might be a more acute and helpful indicator of nutritional status on the short term. Health promotion strategies include keeping the patient's skin clean and dry, proper hygiene, making sure that they're adequately hydrated, that they're getting proper nutrition. If they're our patient in the inpatient units, we want to make sure that we assist them if needed, as needed, to change positions to avoid pressure points. We want to make sure that when they go home or when they're out and about, that they're protecting their skin from the sun. Also, there was a push many, many years ago about the importance of eye protection from the sun as well. That actually interest is now dwindling down, but we need to be aware that it's important to also use sunglasses if you're going to be out in the sun. Our interventions may include preventative measures such as assisting the patient with repositioning as need be to avoid those pressure points. We may have to teach them, or the provider might prescribe some nutritional supplements, some vitamins. The wound care team might have to debride certain wounds. Over the course of like the last 23 or so years, the use of wound vacs or vacuum assisted closure devices has become very, very popular. The wound vac pumps themselves now are so small, they will actually send patients home with these devices in place. They could undergo interventional procedures, and what's not listed on this slide is the use of hyperbaric medicine, which can increase oxygenation and promote wound healing. Let's look at a few practice questions. You are assessing a patient who reports traveling often, smoking, and eating fast food regularly. Which assessment finding requires immediate nursing intervention? First, cool, pale feet. Sounds like there's potentially a perfusion issue. Temperature of 99.6. That's a little elevated, but it's not too bad. A BMI of 38, elevated, not necessarily an urgent, immediate thing. An allergy to animals causing shortness of breath. Now, pay attention that this is saying that they have an allergy to animals, but it's not saying that the patient's currently experiencing shortness of breath. You already know the answer is A. Pale, cool feet are going to indicate that there's impairment in perfusion, and there could potentially be tissue loss if we don't act quickly. Patient tells the nurse, I am not really interested in sexual intimacy. which nursing response is appropriate? How often do you have sex? Do you not find your partner attractive? Would you consider seeing a mental health professional? Have you experienced pain or difficulty with intercourse? The answer is D, asking if they have pain or difficulty with intercourse. The other selections, asking how often they have sex, has really nothing to do with the patient's concern. I'm sure you know that asking whether they find their partner attractive is inappropriate. And really offering a referral to a mental health or behavioral health professional, it's kind of a little early because we haven't really identified that that's the reason for the patient's concern. Next, the nurse is caring for 4 patients. Which individual does the nurse identify at the highest risk for a cognitive concern? A 19-year-old with a viral infection and an ankle fracture, a 26-year-old who just received a tetanus shot after stepping on a rusty nail, a 44-year-old with diabetes who's meeting with the dietitian, or a 69-year-old who drinks 3 to 4 beers daily and had surgery under general anesthesia this morning. The answer is D, the 69-year-old who drinks regularly and is emerging from general anesthesia. Here are the risk factors for cognitive concerns. Notice towards the bottom, there's general anesthesia, especially older adults. 69 is not terribly old, but it is starting to enter that age where we would be concerned that there could be delayed emergence. The individual that drinks alcohol regularly and just is emerging from general anesthesia is at highest risk. If they do have an alcohol use disorder and they have exposure to prolonged ethanol or alcohol, there could also be damage to the liver, which could result in even further impairment in clearing certain medications to include anesthesia. The others don't really pose a real high risk. The 19-year-old, the responses did not say that they had additional risk factors. Yeah, it's a virus infection, but it wasn't prolonged. It wasn't associated with any other condition that we should be worried about. The 26-year-old, okay, so they got their treatment for the stepping on the rusty nail. And then the 44-year-old has got diabetes, but they're just seeking nutritional support at this point. They're not necessarily any higher risk than that 69-year-old that has those 3 risk factors. That concludes this chapter.